That's what we did with the nutrient on Tuesday.
It's okay, it's fine. I mean, I'm I'm maxed out. Like I am maxed out, dude. I'm making it though. We're only going to have one question today, so I'm going to give a little bit of time for people to trickle in. Because you know how like the beginning of the units, we don't have a Kahoot to review. So it's just going to be the color poll, favorite color poll again, but it's just so I can get you guys' attendance. Then I want to touch on, like we saw me pulling up exam questions. There's several exam questions that many people were putting the same kind of answers on, and it's stemming from how we're thinking about the wording and using like basically like when I talk about a term or present it in like a lecture or in the study sheet or somewhere else, people are getting really stuck on word recall, and it's not doing you any favors. And so we're going to talk about that today, and we're going to be approaching our lectures from now on. Most of my chapters, most of Unit 4, will be ending the lecture early, like a good 10 to 15 minutes early. And so we'll go over the questions. I'm not going to pick specific people anymore. We're just going to like have like a question, and then I hope that people will come up with an answer all together, and we can discuss it on those last 5 questions. And then after that, we are going to try to do some meta application of the knowledge that we're learning, so we can start trying to work on improving our critical thinking and not word recall, right? And so we only have a month left to try to work on that stuff. So we're going to try to do as much as we can with that as possible. From everything that I am getting, I know that a lot of my students are also in Dr. Shearer's class. Some of you aren't, but many of you are, in all of my sections. And so I know Dr. Shearer is kind of touting this mentality of like, you should have known better to use the study guides, and, you know, shame on you now that you know you shouldn't have been using that and whatever, blah, blah, blah. I feel like that's inappropriate. This was a handout that was handed out to you guys from the university. This is not you guys' fault, and you guys should not be shamed for it, period. So that's my personal stance on it. And as angry as I've been getting over the situation, I am not mad at you guys at all. Like, I want to be very clear about that. I'm mad that this person in the STEM lab was handing out, you know, the answers to tests, not just from my class, but other professors' classes. And, you know, basically, you know, putting you guys in a situation when people get to my class, and I make it very, very clear throughout my entire class that I expect you guys to be able to understand and apply, right? And regardless of whether or not you're relying on the study guide to help you through that, most of my students were like, they'd have the study guide and they're also trying to learn in addition to the study guide. Like, that's like 90% of people that had the study guide. And so it's not like you weren't making that effort, but it also like took away that like having to rely on the critical thinking aspect. And that's like really like what's going to get you through nursing school. So when we talk about I know some people are going into vet tech. This is stuff that'll help you with that too, but I hear more from my nursing students because I have more of them. And so when you guys get into nursing school, just because you get into nursing school does not mean you're getting a nursing degree, period. So it's like, and that's again, like people I'm hearing, you guys think we don't hear what people say behind our backs, but it comes back to us. So I'm hearing a lot about how like I've been mean about the situation. I don't really care, like anything I mean and whatever, that's not the issue. But the fact is, like, these are facts that I'm telling you. And so we have to face these facts. And like, if you are not prepared for the critical thinking that is required of you in the nursing program, you will not make it to the NCLEX. You won't. Half of the students that go into that program don't make it through. I don't mean they go to another program and get a degree. They're not ever going to get a nursing degree. Because if you don't make it through OSU's program, the other programs will be like, what happened? Why? Good luck getting into those programs. That's not how it works. You don't get to just like keep going into programs and throwing thousands of your dollars out at those programs and just eventually you'll get a degree. That's not how it works. So with OSU OKC, yes, we have one of the highest pass rates with the NCLEX in the whole state, and that's usually what draws a lot of people there. Also, the affordability of the classes as well, and that's great. But that's for the people that make it that far. The people that actually make it to the NCLEX, and half of the students don't. And so the biggest issue, if you talk to any of the faculty, not the students that are in nursing, but the faculty that are in nursing, they will tell you that the quality of their students' ability to critically think and actually apply the information is bad. And that is the number one thing that they struggle with. And I try so hard to try to instill that in you guys, but having the answers on the test to fall back on doesn't instill that practice. You know what I mean? So like, that's the problem with that. And so we've got a month for me to try to like kind of whip you guys into some kind of shape to be prepared for nursing school. Or if you haven't taken Dr. Shearer's class, to prepare you for his class. and the critical thinking, because his class is definitely on par on difficulty as far as like application of the knowledge to my class. Those are the two hardest classes you're going to take before you go into nursing school. And then the nursing school classes are harder. And so that's why like I want to prepare you guys for success and not for you guys to like always have been relying on fallback for like recall stuff. Because it is a fact that on the tests that you're going to take on the nursing program, those tests, all the answers are correct answers. It's just which one is the most correct for this situation. And recall is not going to do you favors with that. So I want to get you guys more in gear with the critical thinking stuff. So we'll do our Kahoot here in a little bit. I'm going to wait just like on 1 more minute to make sure we've got people trickled in and signed in. We'll do this, then we'll do our lecture. And then after the lecture, we're going to try to start getting some like bigger thinking involved to help practice the critical thinking before we get to the test. Yeah. So you can get the idea of like at the end of this semester, what I'm expecting from you guys with your knowledge of this. So don't let your other professors try to convince you that this is, you guys did something bad, because you didn't. Period. I will be in the STEM lab today from 2 to 4. I have a class at 5:45, so I'm gonna try to like get some things done between the 4 and the 5:45. It's been a lot, man. I'm trying to accommodate all this stuff, but I'm trying to donate the time that I can to the STEM lab so that you guys have some kind of tutor there. And like I've said it before, but I'll say it again, that I'm no expert on anatomy or physiology, but I'm pretty good at like figuring things out. And I feel like it helps to have somebody that knows how to figure things out, help you figure things out. And so if you want that sort of help with any of your other STEM classes, I will do that for you for those classes as well, not just microbiology. So I'll send an announcement out for reviewing for the lecture final. So we don't have lab on week 16. We'll be done with lab completely. And so those days where we would have had lab time during our regular lab time on week 16, on Tuesday of week 16, I will like do a general kind of what you would expect from a review, like touch on the major topics in genetics, aerobic respiration and metabolism, and immunology. I like go over like some of the major points with that I feel like, you know, going back, looking at students' performance on that stuff. And then on Thursday, we are going to have a review of some big picture ideas. And so what that means is like things like, you know, if you get a flu infection, the flu virus gets into your body. First of all, what does your immune system do? That's a big question. That's a big question. And so like thinking through stuff like that, as well as like, hey, if the flu virus gets into your body, how does it make copies of itself, transcription, translation, and stuff like that. So these are like meta questions that we're going to start to I'm going to try to go through some questions like that on Thursday on week 16, and questions like that as we're going through the rest of unit 4, because now we're in unit 4 and we're talking about some of these guys, and you'll see what I mean when we get into discussion. My nose is so itchy today. Yeah, starting to get that critical thinking and like application like immediately in while we're thinking about this stuff, so we can start to get our little brains thinking less on steering away more, if we can, as we can, from word recall. And I think some of us will be surprised if you end up going over your tests with me, because again, I'm not opening them up, right? So anybody that comes to discuss their test with me, I think you'll find that the questions that you're getting wrong was due to a reliance on word recall. That's like 90% of the questions that people are getting wrong. Some of it is just like mistakes, you know, we make mistakes. But some of it is, oh, this word, but you said this word in this lecture about this thing, and that's why I thought this answer. Yeah, but that doesn't make that answer right. And that is the problem that I'm seeing on the test. So anyways, we'll do that. We'll do this first, and then we'll do that, and then we'll get into the lecture. So again, just gonna ask you your favorite. We've done it before. So I just need to get, this is easier for me to get the attendance this way than passing around paper and missing somebody. Yes.
There's an answer that's correct, but it's not all the way back through for the complete answer as well.
What do you mean?
So like, if Like, which is the best? And it's like, so like, yeah, because I've heard that's kind of their.
That is how nursing school's tests are.
It's like, they're all correct.
They're all correct, and this is the most correct for this situation, yeah. So some of mine kind of have been that way, right? And so we could, a few of them have been that way. I mean, I don't mark them as that, but that is the case. And so it's like some of my answers on some of my choices, like people will be like, oh, well, I felt like this is a better worded version of this. I'm like, actually, it doesn't cover all of this topic if you really break down what that topic is talking about. And so one of those was with the therapeutic index question. There's a question about therapeutic index on the test. And a lot of people were either answering just based on some word recall, and we can try to find that one too and touch on that one. But also based on like, they were selecting the answer that was the definition of selective toxicity for the therapeutic index. And those are different things. And so a lot of people were either selecting just one of the choices that had ratio, or they were choosing the one that had the selective toxicity explanation, which is a broader term. It's a concept, right? So selective toxicity is the concept that you would want to, let me get out of this. You want the drug to kill the bad guy and not harm the patient, right? That's the concept of that. But the ratio of the actual numbers where it kills the bad guy and where it's toxic to the person, that's the actual therapeutic index. And so I'm gonna just do a couple of questions from the test. We'll do that one specifically so I can show you what I'm talking about. That was something I was trying to make clear, is that Unit 3 exam will not open for you guys to review. You will not get to see your questions or your answers unless you come to me. And then I will review your questions with you. And when we do that, you will not be allowed to take a picture or anything like that. So this is a rule coming to me from my boss. This is what Luke Rhodes has put in place for me. He's my boss. And so he has basically said, like, when we originally had this issue, he thought it was students leaking the exam. It was not, obviously. Right. So like yeah, but he says for the future, to prevent students from leaking the exam now, to protect our stuff, we shouldn't be allowing you guys to have that. Because people will just put it on Chegg or whatever. He says that, but like, my exams never got on Chegg. My exams never got anywhere else. My exams were given out by a person that worked for the university. So what can you do? I don't know. So for what it's worth, that's what precaution I was told to put in place with that. This is chapter 19. So chapter 19, we're going to be talking about the diseases of the skin and the eye. So I'm not going to test you on what the different levels of the skin are in my class, but I just expect you to know that if I talk about epidermis or dermis or the subcutaneous layer, that you know that those are like in succession from out to in, okay? So most people know epidermis, epi means outside. So epidermis is the outside layer. And it is some like living cells as well as dead cells that are kind of adhered together by this protein called keratin, which is a waterproofing protein that gives protection from things getting into the body. As sort of like protection layer. The dermis is more going to have more capillary action getting into it, as well as where your follicles and your glands are going to be found. And then the subcutaneous layer, where we start having that fatty tissue getting involved, a supporting layer to that. So I'm not going to test you over that stuff, but it would help for anatomy stuff and physiology stuff, but I'm not as worried about it in my class. We're going to talk about some of the different lesions that come along with infection in the skin, as well as some of the innate sort of built-in first line of defense. And so that was another thing I wanted to touch on. We have the first line, the second line, and the third line of our defense in our immunity. The first line of defense is like things like you have keratinized skin cells that protect you from things getting in. We have eyelashes, we have nose hairs, we have acid in our stomach, we have saliva that has lysozyme in it. Those are first line of defense. Second line is going to be innate immunity, and third line is going to be your adaptive immunity. And so this is basically listed in order of the things that the microbes are going to see. First line, if we can prevent them from even getting in your body by having a keratinized skin layer, that's your first line of defense. And so that's why they're named that way. Anyways, many of the like sebum and oils and secretions in your skin cells have antimicrobial peptides that can prevent growth of microbes. We also have pH that can affect microbes being able to grow. So the low pH of sebum, as well as the fatty acids that are antimicrobial. Sweat is low pH and high in salt, which is why we mostly see gram positives that are able to grow on the skin because they're able to deal with the high salt concentrations and the osmotic pressure that's associated with that. Lysozyme, we've talked about this in chapter 15, but to remind you guys again, lysozyme is an enzyme that we find in our sweat, tears, and saliva that specifically breaks down peptidoglycan. Overall, the biome of your skin, most of your skin is inhospitable because it is so dry and there is so much salt and the low pH and everything. But in our moist areas and folds in your skin, those are going to, and in your follicles themselves is where you'll find your biome primarily. So your biome, most people, the most common 2 organisms that are part of your biome are going to be Staphylococcus epidermidis. I mean, it's in its name, right? And Propionibacterium acnes. So whenever we hear on like acne commercials about, oh, it controls P. acnes bacteria, the most common cause of acne, that is true. It is called Propionibacterium acnes. And these 2 bacteria are extremely common on the biome of pretty much every person. About 4% of the human population. So we would call this uncommon, but it's not rare. It's uncommon to have Staph aureus as part of your biome. About 4% of the population can harbor it. It is a potential pathogen if it grows in too high of a number in certain areas of the skin. So there's that. But we're going to talk about some of the lesions that are associated with the skin as well. So when we talk about blisters, or these are also known as bulla, these are large vesicles that are filled with fluid where we have separation of the skin layers. We'll see the blistering when we have blisters associated with burns or with friction, as well as with gas gangrene when we talk about that. Cysts are larger raised lesions that are semi-solid or solid when you touch them. A macule is something that has a color change. So it might not even have, like, you would touch it and it'd be just smooth skin, but if there is a spot where there's a color change, this includes freckles. So this is an area that we would consider a macule. And that your freckles might be part of your normal anatomy, but that it's still considered a macule as far as what skin, features are called. A maculopapular rash is a mixture basically between macules and papules. Papules are small elevated bumps. So when you get a little bump that doesn't seem like a fluid-filled vesicle, it's just a bump, that would be a papule. This includes things like warts. So it's a raised skin lesion. It's papule. So maculopapular, we have color change and raised bumps going on. Petechiae, these are small breaks in the blood vessels. We often see them as like little tiny spidery sort of breaks. They'll look like sometimes even spots under the skin, that reddish spots that we can sometimes get, but they're from burst capillaries. Small ones are called petechiae. When you have larger ones, we call it like larger areas of burst blood vessels under the skin. We call that purpura. Cellular like bruising is basically what it looks like. But it's a reddish purple discoloration that when you press it, it stays reddish purple. It doesn't disappear. A plaque is elevated slightly. Yes. It can be, yeah. So people are more likely to have petechiae if they're low with platelets because the platelets are important for clotting. So they can prevent, if you have a good platelet count, it prevents that leaking out and causing those little burst blood vessel areas, yes. So we see petechiae in a lot of situations, like if you were to have someone with asphyxiation, we can have bursting of the blood vessels under the skin or in the eyes, and we'll see petechiae from that small bursting of blood vessels. Larger areas where we have blood buildup under the skin, those are the purpura. A pustule is like what it sounds like, it has pus in it. It's an elevated lesion with pus, or the plaque. The plaque is when we have a flattened area of the skin that is clearly like a dry patch or something like that. It's deviation from the normal skin texture, but it's flattened. When we have it scaling and actually starting to peel, that is called scale. And then a vesicle is a fluid-filled lesion. When they're large, they're called bullae, but when they're small, little individual fluid-filled lesions, this is what we see like with the chickenpox, but it's also very commonly what we would refer to the morphology of the lesions associated with like herpes virus. You have the fluid-filled lesions associated with that as well. So those are vesicles.
What about like skin tufts?
So those would be considered within that realm of the papule like category. Skin tags, many of skin tags are also associated with, we have a genetic predisposition, and they are also related oftentimes to like metabolism and metabolic situations, but they are also linked with the same thing that causes warts, which is HPV. So it's just like which HPV virus is associated with it. HPV, there's like a ton of different HPV viruses. It's not even 15, it's like 150 or so. Yeah, like it's a ton. So some of them are associated with warts and some of them are associated with like cervical cancer, for example. Some of them might have no symptoms at all. And so HPV, there's just a ton. And any wart ever, and some skin tags too, are associated with HPV infection. So it doesn't matter if it's genital warts or any skin wart or any of them, they're all HPV.
You're not getting it from a frog.
Right, you're not getting it from a frog, yes. It's from people. It's extremely contagious. We'll talk about HPV when we get into the sexually transmitted diseases area. That's chapter 24. But to put this in perspective as to how common HPV is as a sexually transmitted disease, HPV, when we're talking about the ones that cause cervical cancer or genital warts, they estimate that 90% of all sexually active adults will have had HPV at some point in their lifetime. It's at least that number. Like this is the documented number. It's probably higher than that. It's probably closer to 100%. If you've only had one sexual partner and they've only had one sexual partner, then those people probably not as likely. But HPV is extremely communicable. And most people have it. It's not one that is a reportable sexually transmitted disease. It's so common that like we just expect people will have had it at some point. Some of those HPV viruses can cause cervical cancer, and that's why pap smears are so important for screening. We'll get into that a little bit more in chapter 24, but a lot of people always have questions about that. So you can start thinking about that now, but it's fine. So getting into MRSA. MRSA stands for methicillin-resistant Staphylococcus aureus. So Staphylococcus aureus in general can cause soft tissue infections in the skin. And MRSA is just a version of staph that is resistant to the antibiotic methicillin. And so if it's resistant to methicillin, it's probably resistant to a lot of the other antibiotics that we used before methicillin. Because it's a strong, not an initial antibiotic that we would reach for initially. So it's definitely, if it's allergic to, not allergic, it's resistant to methicillin, it's resistant to like ampicillin. You know what I mean? Like the basic, like amoxicillin is resistant to those basic guys for sure. Still usually treatable with like vancomycin or something like that. But vancomycin is pretty hard on the kidneys. So we don't like to reach for those drugs if we don't have to. Same thing with like carbapenem and stuff like that. Carbapenem is dangerous. We don't like to give it, but if we have to, we will. So MRSA and any other staph infections, these are very common infections, even in people who are not hospitalized. Even MRSA is common even outside of the hospital. So don't think that like just because you have a skin infection that it's not MRSA because you weren't in a hospital. No, people can transmit that easily. It's just transmitted in society. It's transmitted typically by touch, by contact. And so if you get like a pustule on your skin that's taken a little longer to heal, it might heal on its own or it might not. That is typically going to be associated with staph. And so these staph infections, you're fine. Staph infections that are associated with that stuff, we will see a pustule that's forming, usually filled with pus. The area will be hot to the touch, and fever can be a common feature if we have this ongoing, especially if it's spread to other areas of the body. You usually get staph infections through breaks in the skin, being exposed to staph bacteria. And then pustules associated in those areas from that. This is caused by the organism Staphylococcus aureus. Staphylococcus aureus obviously is a gram-positive coccus. We know it's coccus because it's in the name, and we know it forms grape-like clusters because staphylo means that, right? So we know that it is gram-positive, and you do need to know that. It is non-motile. This is the sturdiest of all of the non-endospore-forming pathogens. It can withstand high salt, extreme pHs, and high temperatures. So this guy can be harder to get rid of than the typical vegetative bacteria. Drying is pretty resistant to that. Why did it do that? Okay. For pathogenic, and so for the virulence factors. So we've talked previously about what a virulence factor is. A virulence factor is anything that gives an advantage to an organism causing disease in the body. So these enzymes help with disease causing in Staph aureus. Coagulase is an enzyme that coagulates plasma. Hyaluronidase is an enzyme that breaks down one of the hyaluronic acid, one of the molecules that are important for our extracellular matrix. So this helps with penetrating into the tissues. And there's some of these other enzymes as well that are features of this organism that are associated with its ability to cause disease. But the coagulase test is a defining test for Staphylococcus aureus. So we will take plasma, quite literally plasma. So we usually typically use rabbit plasma as a controlled, usable medical way to test this. So we'll take plasma from a rabbit's blood and mix it with your patient's sample. If it coagulates, it will be positive. So it could be chunky or it could like completely solidify. But if we see coagulation of the plasma, when we mix it with the patient sample, it produces coagulase, and this is a defining characteristic of Staphylococcus. All right, moving on to our different skin infections that can be associated with staph and other bacteria. Impetigo. Impetigo is a flaky skin infection where we have exfoliation of the skin in addition to the infectious process. Which is pretty common in kids. We see this sort of flaky skin infection in kids. It's called impetigo, and it's usually associated with Staph aureus or I'll say Streptococcus pyogenes. Right. So usually, what happens, it seems like from our studies, we're seeing Streptococcus pyogenes start the infection, and once it starts to clear out stadium seats by creating its toxins and killing off the biome and whatever, more stadium seats are available. Staph aureus can then overgrow and even kill Strep pyogenes with its toxins and ability to take over after that. And then Staph aureus takes over. So typically it progresses to Staph aureus taking over. But we think that it starts off with Streptococcus pyogenes. And interesting to think about that. But staph also creates these toxins called exfoliative exotoxins. So it secretes these toxins that leads to the cells like separating from each other essentially and flaking off. That's where we get that flaky appearance from this. And remember, the coagulase is also going to coagulate the plasma in the blood. So we see this flaky sort of dry flakiness associated with this from that. Streptococcus pyogenes, which is also associated with this. Strep pyogenes is a gram-positive coccus. Obviously, it's strepto, so it's going to be in chains. It's beta hemolytic as well, which is a defining characteristic of it. Streptococcus pyogenes is associated with strep throat, scarlet fever, pneumonia, puerperal fever, necrotizing fasciitis, bloodstream infections, and rheumatic fever. So this guy dips his little toesies in a lot of different kinds of infections here. When we talk about necrotizing fasciitis, we're talking about necrosis, which is death of tissue, and fasciitis means in the fascia. So we're like down into the deeper levels of the skin here. So we can even have introduction of Streptococcus pyogenes through like a minor abrasion, and it will continue to migrate through the deeper layers of the tissue and then cause necrosis of the deeper layers of the tissue and cause it to slough off. And that's what we see with necrotizing fasciitis. It's a very fast progressing disease. It's caused by a lot of different bacteria can cause it, but it's commonly associated with Streptococcus pyogenes. It's one of the more common causes of it. When we talk about flesh-eating bacteria, it's this necrotizing fasciitis. It's a very fast spread. And so what they do when you see like on TV shows or in hospitals, if you've been working in hospitals, especially in ERs, where you have like somebody who has redness in their skin and it's hot and it's tender and you suspect it's an infection under the skin, you draw a line where the redness is. If it spreads past that line in a certain period of time, then we are going to almost immediately diagnose it as necrotizing fasciitis. And so that's what they'll associate with. And they'll start debriding the necrotic tissue. And that means literally cutting away all the infected tissue. That's what debridement is. And they'll try to leave behind the healthy tissue that hasn't been affected yet and then treat that tissue with antibiotic creams and washes and as well as intravenous antibiotics to try to get at it from all sides. But it's extremely difficult to control necrotizing fasciitis. It usually results in limb loss. So it can be very dangerous. And it's not uncommon. We think of it as being like something we see in the horror movies or like in Cabin Fever or some of those really horrible. It's awful. If you haven't seen it, don't see it. So, but it's about necrotizing fasciitis. And we see it in like some of those situations, but it's actually something that's pretty common in folks. Spider bites can lead to it as well. The spider bite toxins will lead to death of the tissue. Then the bacteria can come in and infect the area, and then the bacteria will then spread from there. And so that can be pretty commonly associated with the spider bite leading to the necrosis in the local area and the bacteria taking over beyond that. So that's possible too. So these guys also have some elements that are helpful for them to cause disease, like hyaluronic acid capsule. So if I've already told you that we have hyaluronic acid, in our extracellular matrix. And this guy makes a capsule out of the same molecule that we have in our own extracellular matrix. It covers itself with a self molecule. And so it makes it hard for our body to fight against strep. And so that's why it can be hard for us to fight our strep throat infections and why we often need antibiotics to fight it. Our immune system has a hard time dealing with it. Strep pyogenes, we often diagnose this by looking for beta hemolysis on a blood agar, as well as its sensitivity to bacitracin. So this is a time where we can actually use Kirby-Bauer for a diagnostic tool, as a phenotypic diagnostic tool. So we can look at basically the size of its zone of inhibition and compare it to, okay, so this is the patient sample. It has this size of zone of inhibition around bacitracin, and that's what we expect for strep, as opposed to staph, as opposed to these other organisms that could cause disease. Moving on to cellulitis, this is a spreading infection in the dermis and the subcutaneous tissues. So this is something that could eventually lead to a necrotizing fasciitis sort of situation. These are deep tissue infections that are not on the surface of the skin. And so this is spreading within the deeper tissues underneath the surface of the skin. And it doesn't necessarily even require a break in the skin. It just requires the bacteria got in there somehow. And so this can lead to spreading of infection within the skin, deep tissues. And it's very common what we see in the lower leg, especially folks with diabetes, who have low circulatory system, in those extremities, as well as people who have, immunocompromised situations as well. Next is staphylococcal scalded skin syndrome. Here's what it sounds like. If you were to burn your skin and have scalded skin, staphylococcus infection causes a similar effect. It's from those exfoliative toxins, but this is a systemic version of impetigo, basically. So the exfoliative effect of impetigo, just in certain areas localized, maybe to the scalp or to the face, this is like all over the body. And so this is usually seen in young children and babies. And those exfoliative toxins are leading to what we call bullous lesions, the large, basically blister areas on the skin. So this is an image of an adult with staphylococcal scalded skin syndrome. I had a nephew that had this and had to be rushed to, he lived in Kansas, and my cousin had to take him, I say nephew, but it's my cousin's kid, I call him a nephew, right? So, right, whatever. My cousin's kid, she took him to Denver. They live in Kansas, but they drove all the way to Denver for a specialist for this because it was so widespread. I mean, his whole body was having this sort of blister effect from a staphylococcal infection. So Stevens-Johnson syndrome is related to like an autoimmune issue that can be triggered by having an infection like this. And we think that something is related with this. There's a lot going on, and it's not just the infectious process, but also the body and how it's responding to it. So kind of, but yeah, it's a lot more to it. Yeah. So gas gangrene is our next one. Gas gangrene is known as clostridial myonecrosis. Myo means muscle. Necrosis means we're actually having death of tissue. So we're talking about death of the muscle tissue from this. Now, clostridial species, like Clostridium perfringens that causes gas gangrene, these guys are anaerobic species. They don't live in the presence of oxygen. They die from oxygen just being around them. So they live as endospores. They're endospore forming. And then whenever they get into deep tissues, they're able to cause the infection. And this leads to anaerobic respiration. And these guys, they use sulfur-based compounds and they reduce sulfur, and it creates hydrogen sulfide gas. And when that happens, it releases the gas into the tissue around it. So we'll have swelling of the tissue from the gases that are being produced from these clostridial species, and can lead to swelling of the tissue that's so bad that the skin can't contain the swelling tissue underneath it, and it will rip the skin open, or we'll have leaking of the fluids from the edema, from the inflammatory response, leaking the fluids out. So your skin will just start leaking fluid or developing these huge blisters that are filled with black fluid from the necrosis, as well as the products that the bacteria are making. So gas gangrene is no joke. There's two different versions of gas gangrene, the dry version and the wet version. Yes.
I'm pretty sure one of our coaches got this, and he had to have like skin grafts.
Yeah.
And stuff.
Yeah. It's actually pretty damaging. So just to be clear, Clostridium perfringens that causes this, that bacteria is very common in the environment. It's found in the soil, it's found on skin, it's found in the vagina, it's found in the intestine. Like, it's kind of a pretty ubiquitous bacteria, but you don't want to get it into deep tissue places where it doesn't belong. So gas gangrene, this is like the dry version of gangrene. There's two different versions, the anaerobic cellulitis, which is kind of localized, and the true myonecrosis, where we spread to even healthy tissue and continue to spread beyond that. Now, gas gangrene is something that we see associated with like old, battles with like bayonets and people getting stabbed, and then they get gangrene afterwards. And this can be introducing the bacteria from the environment or releasing it from the gut or whatever it was. But gangrene, again, like you can have swelling of the tissue to the point that it would rip the tissue open. So oftentimes when we start having the wet gangrene where we have that swelling of the tissue and the leaking of the fluids, we will also perform fasciotomies. So fasciotomy is where you cut the skin open so it won't rip itself open. You give it space so that it can swell. And so this can be due to trauma or it can be due to infections. So if we have trauma or if we have compartment syndrome, or like we can't have movement of fluid out of an area and the area is just like swelling up, if that continues to happen, the body will just rip itself open from that. And so to prevent that, because that's going to lead to more infection, it's going to be harder to heal it later. We'll just cut it with a sterile scalpel to allow it that room to expand, and then we can surgically unite the skin and tissue back together as needed later on. So what actually happens in the muscle tissue, this is a cross section of muscle. The white in there in the middle is the gas-filled spaces. So it's just expanding all of this muscle tissue, leading to muscle damage, tissue damage, expansion of fluid, filling in the spaces as well as leaking out of the tissues and stuff like that. So that's gas gangrene caused by Clostridium perfringens. It is an endospore-forming gram-positive bacteria. It is anaerobic, and all the dark little spots in here are the bacteria. And it produces some of these toxins here that are associated with the disease progression. Again, those would be called virulence factors. Moving on to our vesicular and pustular rash diseases. Oftentimes when we have small vesicles forming in a disease, we call those pox. And so this is common for chicken pox, smallpox, and monkeypox. Monkeypox is very similar to smallpox, but it's not as serious and it's not as contagious either. So hand, foot, and mouth disease is another one, just so you know. It's a very common one in kids. They get the vesicular rash that's associated with that, and they can get it on their trunk and in their mouth. They'll get little like spots in their mouth and on their palms of their hands and butts and stuff like that. But it usually passes on its own. It's usually a harmless disease. So chickenpox is our first one. Chickenpox is a viral disease. It's caused by a virus that we call varicella zoster. It's also known as human herpes virus 3. It's a herpes virus. It is potentially life-threatening in people who are immunocompromised or who are older. This disease will not just cause pox like what we see in small children. And this is why we want you to get it as a little kid or get vaccinated, because it's safer for you to have as a kid when you have a stronger immune system. The older you get, the weaker your immune response gets, and the more severe this disease can be because the immune system can't deal with it. So we have that. There's 0.1% of cases that will be involving encephalopathy, or will have a brain infection resulting from this. So it can be life-threatening if that happens. And when we say 0.1%, and that might not seem like very much to you, but like how many people are getting the chicken pox? Like a whole lot. So 0.1% is probably not a risk you would want to take for your own family, FYI. Chicken pox incubation period is 10 to 20 days. So you go, like I did when I was a kid in the 80s, people went to chicken pox parties. And if somebody got sick in the class, and they just wanted all the kids to get it over with all at once. So they would bring the kids over to the sick kid's house so that you could get the chicken pox. And that's how I got the chicken pox. So, and my mom brought other kids around, me, when I had the chicken pox too.
You said spread, please.
Yes, so all the parents were using that as option. There were no vaccine back when I was a kid. There's no vaccine for it. But so you guys get vaccines now. We had to have the chicken pox. And I have scars all over my body from having had the chicken pox as a little kid. I had it when I was 7. So 6 or 7, something like that. Anyways, you get exposed to it, and 10 to 20 days later, you'll get symptoms. So this is an incubation period due to the lag phase of this viral infection. It just takes that long for it to like get started and building up in the body and for the immune system to start reacting. And we start having the itchy, vesicles that are associated with pox there. Usually resolves, starts getting like, will have peaked and start getting better after about 5 days, but it takes about 2 to 3 weeks to fully resolve. So when I have scars all over my body from chickenpox, it's not from the pox, it's from the secondary infection. So when I was a little kid and I would scratch it and whatever, then staph or streptococci bacteria. And it wasn't just staph aureus, it could be staph epidermidis or whatever, but it got into places where it didn't belong on my skin and leads to skin infections. This is extremely common with the chickenpox because little kids get it and they don't know better than, you know, they use their nasty little nails to scratch at their skin and leads to skin infections and whatever. That's what causes the scarring. Shingles is when you have reactivation of chickenpox. If you have never had chickenpox and you do not keep up with your boosters for your chickenpox, then you can get a version of chickenpox that will present very similarly to shingles. However, if you've actually had chickenpox and it reactivates as shingles, it comes out along the nerve where the virus was hiding out.
Question, is like how susceptible you are to shingles genetic in any way?
Yes, so it relates
My mom
to your
has
immune system.
repetitive shingles.
Yeah.
So I was just.
Yeah, it's basically your immune system's ability to keep it in control. So I've had chickenpox and I've never had shingles yet, but that doesn't mean I won't get it, right? So I might get shingles later on in life. I can get a vaccine that boosts my immune system and make sure that my immune system stays healthy and strong and will always keep it at bay. But some people, their immune system just don't react strongly enough to it and they can't keep it at bay. So that is related to their genetics, yeah. So moving on to smallpox. Smallpox is a viral infection caused by the virus variola. So we either have variola major or variola minor. Smallpox, variola major is the more commonly like discussed when we talk about smallpox. So we have these, it starts off as a macular rash. So it starts off as dark spots. Those dark spots become papular. So we start having raised lesions. So dark maculopapular, dark raised lesions that will turn into vesicles and then eventually evolve into pustules. So we get these all over the skin, just like this. It's very disfiguring. If you were to survive smallpox infection, it led to a very disfiguring scarring afterwards. And so it was extremely, it's very, very communicable. It's very contagious and deadly. So we're talking about, you know, mortality rate of about 30 to 50% from these guys. So that's smallpox, extremely contagious, 30 to 50% mortality rate. And so you might be like, yeah, I've never seen anybody that has this. It's been eradicated from the planet since the 70s. Nobody has had smallpox since the 70s. And so we don't vaccinate for this anymore because it doesn't exist on the planet. However, the United States, Russia, and China that we know of, there are other countries as well that probably also have this stored in cold storage. So we're talking like deep freeze. So I know for a fact that the United States does because when I worked with the CDC, they talked to us about how they would store smallpox. They have like basically 50 different boxes that it could be in, and it's only in one. There's like 50 that it could be in, and those boxes all get rotated like randomly at random different times, at least once a month. And so there's no one person that knows where it is at any given time. If they had to track down where it was, they could, but they don't know where it is. No one person knows where it is at any given time. They just cycle all these boxes around constantly.
That would be a bad terrorism.
Like, do we keep it on purpose? Or? Yes, because it's a bioterrorism agent, right? So we don't want somebody to be able that works there to have access to it and potentially sell it to another country and let them attack the United States with it. We do not vaccinate for this. 30 to 50% mortality rate, highly contagious. Nobody in here was vaccinated unless you were born in another country. So if you're born in Mexico, they vaccinate for this. So you might be protected. Yes.
So where does it stem from? Do they know the origin?
So nobody gets it, right? Nobody has it. So it's been around for thousands and thousands of years, since the beginning of mankind. We don't know where it came from. It's like one of the oldest diseases ever. And so it's one of those diseases that we,
Is it possible for it to come back?
not naturally. I mean, so
But that's another reason.
not
why I
naturally.
feel like-
So let me say something to put this in perspective for you guys. Why we have situations like we do. If you work in the United States military, you are vaccinated for smallpox. Still, actively today, we still vaccinate our military. Why do you think that is? Because we need our frontline defenders to be able to defend against us if we were attacked with smallpox. So Russia and China have smallpox in their cold storage too. They're probably not like protecting it like we are
That's just
either.
what we know of though, right?
That's just that we know of, right?
Is there one time that was installed?
No, it is not. It lasts for about 10 years, but most people don't have immunity after 10 years. So my mom, one of those people, right? She got vaccinated back when they used to vaccinate for it. And so she has a scar on her arm from it. It leaves a very noticeable scar when you get it. They do what we call excoriation to scratch it into your skin. It's an intradermal and it's like a circular shape and it'll be like a big divot on the arm and it should be identifiable. But if you know anybody that was born before like the 70s, they'll have been, or if you know anybody that's in the military, they'll have been gotten this vaccination. And everybody in Russia gets vaccinated for it, by the way. Every single person still to this day gets vaccinated for smallpox in Russia.
Yeah, my friend that was adopted from Russia was vaccinated.
Yeah, and yes. And so I had a student, I probably was the same person, honestly. Yes.
So I was in the military, but I don't have, like, I know I was obviously fucking vaccinated, but I don't have like a scar like what you're talking about, like my dad has a scar.
Yeah.
So is it?
So were you a child in the military, or you were actively in the military?
I was actually.
You served in it?
Did you ever go overseas anywhere?
Yeah, they probably vaccinated you in your vaccination series, but you probably just didn't know it, because they just like bulk vaccinate you like everybody all at once, yeah. And they don't tell you what they're just like, here's your shots.
Yeah.
Like, yeah. So you probably got it, yeah, and you probably don't have that nose. Most people get that, and so most people do get the noticeable scar, and usually it's part of it. Like if you didn't get appropriate scar, then they're going to assume you didn't. Like it didn't take. Like that's part of the thing, right? So your body may not have developed a good immunity for you. I'm not saying you're not protected, but that potentially you might not be. But yes, but yeah, everybody that goes in the military, like that's just part of like the vaccine series for it. And there's a reason for that because of the risk for bioterrorism threat. And so this is one of the first bioterrorism weapons ever used in mankind. This is when you hear about, oh, the Spaniards came into Mexico and gave the natives that were there, the Aztecs or the Maya, they gave them blankets. And the blankets had smallpox on them. It's the same smallpox. It's been used as a bioterrorism weapon since before, but we knew what that was.
Before bioterrorism was a thing.
Yeah. So this is one of the nastier ones. So anyways, this doesn't exist on the planet actively anymore. People keep cold stores of it. It is the number one biggest concern for bioterrorism, because especially with the United States, none of the citizens are actually vaccinated for it. If you were born in Mexico, they vaccinate for it. So, and we have students that have mentioned that as well. So, all right, moving on to our maculopapular rashes. These are we have color change involved. It's usually just actual melanin that's involved in that color change. And then papular, this is actually like raised lesions. So measles, rubella, fifth disease, and roseola. Some of us have heard of fifth disease. It's the slapped cheeks, like one where the kids will get like the red cheeks and they might have a little fever for a while, but it's like super minor. Almost everybody recovers from it. And almost everybody has been exposed to it at some point. It's super minor. Most people have not heard of rubella or roseola though. So I want to talk about rubella just really quick. Rubella is really like one of those diseases that adults get it and you almost never have any symptoms. Who cares about it sort of a situation, like it's not a big deal. But you notice how it's in the MMR vaccine, measles, mumps, rubella. So if rubella is a super minor disease in people and then you don't really have any effects, why do we vaccinate for something like that? Well, the reason is because pregnant women who get rubella, it's almost 100% abortive. You want to live through that? We can prevent you from having that suffering by vaccinating you for that. Okay. So there's that. Roseola is another one of those diseases that like 100% of us in this room have had it. But it's just one of those diseases you get. It's like a cold basically, and you get over it. And so we don't vaccinate for roseola. Everybody has had it at some point, at least once. If we can show evidence that there's 100% people have had it at some point. It's just a minor thing, but everybody gets it. So measles, of course, big topic right now. It used to be known also as rubeola, but I won't ever test you on that. But it is, we say this is a textbook that's from 2022, and man, have we had some stuff happen since then. So measles cases have been occurring prior to the COVID-19 pandemic, or once people started getting vaccinated for COVID, and people started seeing that people were protected with that. And the whole reason that we're in this room right now without masks right now is because of the COVID vaccine. So once that started happening, we started seeing an increase in people getting vaccines for measles again. But now, of course, with what's going on in our political climate, and do what you want to do, man. But we have our RFK, trying to steer people away from getting measles vaccinations, and it is what it is. But so we have an increased frequency of measles right now. We have a child that is at OU. I think it's more than one at this point, but it's at least one the last time I checked. There's a child at OU Medical Center with measles. There you go. OU Children's at at OU Health Science Center campus with measles right now. They're in the hospital with it. Okay, so I want to make that very clear. They're not at home with the measles chilling and having some soup. They're in the hospital with it. Okay, before the vaccine existed for measles, measles vaccine is one of the absolute most effective vaccines that have ever been invented. In addition to the one that was invented for smallpox, which, by the way, bring this up again. Edward Jenner, back in like the 1800s, noticed that milkmaids weren't getting smallpox, so he noticed they were getting cowpox instead. So I don't know if you know the Latin word for cow is vacca. So vaccines come from vacca. It's the first vaccine that ever existed, was a vaccine against smallpox. He used cowpox on his kid, pushed his kid out into the smallpox world, and he never got smallpox. And that is the first vaccine. That's why vaccines are called vaccines. It came from a vaccinia virus, which was the cowpox virus, vacca. Gotta love it. But he was that confident in it. So you could like, I mean, I wouldn't do that with my kid, no matter how confident I was. I'd test it on some weirdo, but. Right. Mm-hmm. Yes. Just to clarify. Yes.
Crazy thing is that most of like our vaccines or like major medical advancements have come from some pretty unethical.
Yes. So, measles vaccine, before we had it, 6 million people would die every year from the measles. 6 million people died, not got it, died. The measles is one of the most communicable, we'll say contagious, most contagious viruses, probably is the most contagious virus that we've ever discovered in humanity. It's super contagious. 95% of the population needs to be vaccinated to prevent the people who can't get vaccinated from getting the disease. So when we talk about, like, you don't get the measles vaccine until you're at least a year old. So any baby that's under a year old, in order to protect those babies, everybody else needs to be vaccinated. Otherwise, they could die from the measles. So that's why, even if there might be risks associated with vaccines, when the risks for the vaccines are, take that risk compared to dying or having babies die, that's what we're comparing it to. Yes.
Swift told us that like somebody could just walk in this room, not sneeze, not walk in this room.
Yep.
And then leave. Went in that room within 3 hours.
You would get the measles. Yep. It's super contagious.
So
you don't have to cough it or anything.
What kind of room is it? The negative air pressure room? Is that?
Yes, so negative air pressure, so that if you walk in there, air rushes in instead of out of her room, because her just breathing is releasing the virus into the air.
Like 2 doors, so it's like 1 door and then.
Yeah, it has like an antechamber. Yeah, yeah. So we call that environment a BSL-3 environment, and it's what we keep people who have tuberculosis in, because people are refusing to get the vaccines for measles. You do what you want. Tell your family do what you want. You are educated now. Make your choices. So when you get the measles, it starts out with sore throat, dry cough, headache, maybe conjunctivitis, some eye infections. You could have lymphadenitis, which is swollen lymph nodes. And you eventually might get the spots. Not everybody always gets the spots that are the rash that is associated with the maculopapular rash. It's called Koplik's spots in measles. That's what that rash is called. So some people might get laryngitis, bronchopneumonia, and secondary bacterial infections during this. So it starts off as a respiratory disease, and then you get the rash associated with that. So serious complications arise when it spreads into the nervous system. So this can lead to subacute sclerosing panencephalitis. So it infects the entire brain tissue, and it leads to an inflammatory process there that will lead to a degeneration of the cerebral cortex, white matter in the brainstem, will lead to coma and death. Good luck. All right, wart-like eruptions. So these are our papillomas. Any wart is called a papilloma, and it's caused by human papilloma virus, or HPV. There are over 130 different human papilloma viruses. They can cause genital warts, but also just any wart is caused by an HPV virus. Always, like that's what warts are caused from. HPV, human papilloma virus, not frog pea papilloma virus. It is human papilloma virus. It's from contacting people or contacting the things that they've contacted. So walking barefoot in a gym like floor, for example, could be getting that virus, or the fungus like athlete's foot on stuff like that. Cutaneous anthrax. Anthrax is caused by the bacteria Bacillus anthracis. It is an endospore forming bacteria. It does have Cutaneous anthrax is the tamest version of anthrax that you can get. Cutaneous anthrax has a 20% mortality rate. So this should also put in perspective why anthrax is a, bioterrorism agent as well. So yeah. So this lesion that this man has in this picture is called an eschar. I always have a problem pronouncing it. Luckily, you guys won't have to pronounce it, at least in my class, but definitely recognize it on the test, right? So this black eschar here that this guy has, the endospores from the environment got into a lesion on his neck or whatever and was able to penetrate the skin and lead to an infection. So this is the tamest version of anthrax that you can get. There's also respiratory, GI, blood infections and things like that you can get from anthrax. So we might think, oh, anthrax, this is just like a bioterrorism agent, but it's actually extremely common in livestock. This is like a zoonotic disease. So people who have farms where they rotate their livestock land with their actual planting land, they will not till livestock land unless it is within like 3 acres away from like where they'll be doing like actual farming or living. So because after the livestock have lived on it, there's going to be the endospores that'll get like disrupted from tilling that land. So farmers who do this are aware of this and aware of this process. And this is probably a man who was a farmer, probably just got it naturally. You can get anthrax naturally just fine. You don't need to have bioterrorism. Ringworm is caused by fungus. Ringworm is not caused by worms. Ringworm is caused by fungus. The fungi that cause ringworm are called dermatophytes. There are over 39 species that are responsible for these cutaneous skin, is what cutaneous is skin. Mycoses is diseases that are caused by fungus. Mycosis is a fungal infection. So these cutaneous mycoses are caused by fungi that we call dermatophytes. They cause diseases that we refer to as tinea. Yes, we learned about tinea solium. That was the tapeworm. This is just a term for worm that has stuck around because people used to think that ringworm was caused by worms because of the circle shape that it would make. Even athlete's foot falls into this category. It is a cutaneous mycosis. So it's a ringworm. We call it tinea pedis because the feet. All right. So tinea corpus is when you get it just on the body. There's tinea barbae, which is like ringworm that's associated with like beards and all sorts of stuff like that. There used to be pictures, but I'm sparing you guys. All right. The surface of the eye and its disease. We're going to talk about diseases of the eye. The surface of the eye is called the conjunctiva. So the protective layers of the eye are called the conjunctiva collectively. So conjunctivitis is when you have itis, inflammation of the conjunctiva, the protective layers of the eye. The eye secretes oils, mucus, and fluids to help with flushing and lubrication. The cornea is the basically windshield of the eye. It covers, it's a dome-shaped cover of the eye, and it's exposed to the environment. It consists of layers of cells that are able to quickly regenerate when damaged. Tears contain things like lysozyme and other fluids and salts that help prevent the growth of microbes and help flush out debris from the eye. The eye is an immune privileged site. It's because our body would be responding with inflammation to microbes and things like that. And the inflammation that would be associated with that can cause permanent damage to vision. And we needed our vision as hunters and gatherers society. We couldn't risk that. And so we can't risk having too much inflammation in our eye and then damaging our eyesight. So your eye is an immune privileged site. It means that there's less of an immune response there and a different kind of immune response to protect it from the inflammatory aspect of that. Your central nervous system is another one of those. We'll talk about that when we get to that in the next chapter. Conjunctivitis is an inflammatory infection of the conjunctiva, our protective layers of the eye. There's different versions of conjunctivitis you can get. The more common ones will be bacterial, viral, or allergic. Allergic just means you're having an allergy, and then that's led to inflammation of the conjunctiva. So the itchy, watery eyes and the red eyes from allergies, that's allergic conjunctivitis. Conjunctivitis is usually associated also with photophobia, which is light sensitivity. Okay. What we call pink eye is conjunctivitis. Bacterial conjunctivitis, this is going to be associated with a yellowish or milky discharge, whereas viral and allergic conjunctivitis, you'll still have exudate. You'll still have clear fluid, but it won't be milky. So this is obviously an example of a little baby that has conjunctivitis of the eye. It's clearly bacterial with the milky discharge associated with that. First we have, so after that, where did my keratitis go? I thought I had keratitis after that. There it is. We'll go to the keratitis next. And we'll come back to trachoma. Keratitis is a more serious infection than conjunctivitis. It can lead to cornea. So this is keratitis not keratinitis, okay? So keratitis refers to the cornea. Keratitis is the cornea. So inflammation of the cornea. And this can actually lead to destruction of the cornea and its functions and can lead to blindness as a result of that. Things that commonly lead to keratitis, this, you can resolve this, you can get over it, or you can have treatments for this stuff. But most common causes of keratitis are going to be HSV1. So that's the oral herpes. So you can get either HSVs in genital or oral or anywhere, really, honestly. But more commonly associated with oral herpes, like cold sores, is HSV1, and that can get transmitted to your eye and lead to keratitis. Also, acanthamoeba. So it's an amoeba. It is a protozoa, and it's found in tap water and freshwater lakes. So this can get in your own tap water. You probably have it. And this is probably why if you guys wear contacts, you probably heard from your ophthalmologist that you should be rinsing it in sterile saline and not just in tap water. And this is why, because the amoeba can be in your tap water and in your hot water tanks and things, and gets into that and can get into your eye that way. Acanthamoeba is also one of the amoebas that can cause brain-eating amoeba infections. So brain-eating amoeba infections, while extremely rare, are 97% fatal. So don't play with that. And people that survive it, the other 3%, they're not doing good. Okay, so don't play with it. Use your sterile saline solution. Ocular trachoma. Ocular trachoma is the #1 most common infectious reason for blindness in the world. So we have reasons for trauma, we have genetic reasons for blindness, but this is an infectious cause. This is the #1 infectious cause of blindness in the world. It's caused by chlamydia trachomatis. And so if you're like, oh yeah, I know chlamydia, I've heard of that one. We'll talk about chlamydia as a sexually transmitted disease in chapter 24, but it can also, this is the same exact bacteria. If this same exact bacteria gets in the eye, and it is not just transmissible through sexual transmission, it's like through contact. And so, right. And so we're like touching like me using this mouse and then rubbing my eye later. If it had chlamydia trachomatis on it, I could get this eye infection. It's more common in like what we call third world or underdeveloped countries, where we don't have as much hygiene in place with that. But the inflammation causes scarring on the eyelid, and then that scars the cornea, and then that is what leads to the blindness. It is treatable with antibiotics. We already did this. River blindness is our last one. In river blindness, this is a chronic parasitic infection. It's caused by a worm called Onchocerca volvulus. So the name of the illness is actually onchocerciasis, but it's caused by the worm Onchocerca volvulus. The worm itself is transmitted, like the larvae are transmitted by flies coming and landing on eyes of people. So we see this more in third world countries as well. They'll come and land on the skin or in the eyes, and then the little larvae migrate in through the body or in the bloodstream, and then eventually move into the eye. The worm itself can actually be seen in the eye when you look through the iris, swimming around in the eye, and it lives in the eye after that. That worm is actually infected with a bacteria called Wolbachia, and actually most worms that cause infections in animals are infected with Wolbachia. The Wolbachia bacteria lends to the pathogenesis of the worm. This is actually really common when we talk about like heartworms in dogs. So heartworms are infected with Wolbachia bacteria, and if you treat a dog that has heartworms with doxycycline, which is a treatment for bacteria, you can kill the bacteria in the worms, and then the worms are easier to kill because they're not as hardy. Yeah, so this leads to the pathogenesis of the worms. That Wolbachia bacteria, common in helminths, and leads to pathogenesis. All right, so we'll review the questions really quickly. We won't have time for the discussion, and that's fine. Lab's going to be short today. So what pathogen does coagulase test identify? Staph, yes. But which organism causes gas gangrene? Anybody want to call that one out? Yeah. So good. Yes, we're close. We could definitely recognize it on a test from that. Yes. So that one is, yes, Clostridium perfringens. Well, yes, we got there. All right. Measles. Is it caused by a virus, bacteria, prion, or protozoa? Virus. Excellent. What disease does variola cause? Smallpox. What pathogen causes the most common infectious cause of blindness in the world? Chlamydia. Yes, we can just say chlamydia. I won't put multiple chlamydia on the test. Okay. So that's what I'm saying with Unit 4. Recall is friendly for most of Unit 4, right? But there will be questions on your final exam that will like be a little bit more meta,
We're
things
not
like,
gonna have to pick.
and we're not necessarily gonna go over it today because we didn't have time, but something like, okay, if your patient comes up to you and they have a skin infection, what kind of questions would you ask them to figure out how you would want to approach it next? And if you think that it's staph, you know, if we talk about staph being gram positive, what color would it be if you did a gram stain? And then what other tests might you do to confirm that it is staph instead of, so thinking of these things on a bigger scale. And if you even decided, oh, well, I do a PCR test to confirm it, how does PCR work? And that sort of stuff. So actually asking those questions and being able to discuss that stuff. All right, we'll go up to the lab. It'll be a short day in lab today. Yes, I see that you have a thing.
When you say like, and what